Hypertensive emergency. Welcome to today's discussion on hypertensive emergency, a critical condition that demands swift and precise intervention. Let's dive in. Introduction. Hypertensive emergency is defined as an acute and severe elevation in blood pressure, commonly above 180 over 120 millimeters of mercury, accompanied by signs of target organ damage. This could manifest as pulmonary edema, cardiac ischemia, or neurologic deficits. The key takeaway? When acute organ dysfunction is present, blood pressure must be lowered aggressively. However, in less urgent cases, a gradual reduction is safer to avoid hypoperfusion. Etiology. Common causes of hypertensive emergencies include chronic hypertension, noncompliance with antihypertensive medications, and the use of sympathomimetic agents like cocaine or amphetamines. Pathophysiologically, a rapid rise in blood pressure overwhelms the body's autoregulatory mechanisms, leading to vascular stress. This results in endothelial damage, a pro-inflammatory response, and hypoperfusion of critical organs. Pathophysiology. On a microscopic level, this stress often leads to fibrinoid necrosis in the kidney arterioles, a hallmark of malignant hypertension. Clinical presentation. Patients may present with symptoms like severe headaches, altered mental status, chest pain, vision changes, or shortness of breath. On examination, you might find cardiac findings, such as rales, jugular venous distension, peripheral edema, or extra heart sounds. Neurologic signs, including papilledema, aphasia, or ataxia. Renal symptoms, like pulmonary or peripheral edema. Evaluation. To evaluate a hypertensive emergency, conduct a metabolic panel, urinalysis, and cardiac enzyme tests. Perform imaging like CT scans for neurologic symptoms or CTA for suspected aortic dissection. Don't forget an ECG in cases of suspected cardiac ischemia. Complications. Complications of untreated hypertensive emergencies can include renal failure, vision loss, myocardial infarction, stroke, or pulmonary edema. Treatment overview. Effective treatment involves rapid blood pressure reduction in emergencies with organ damage, while a more gradual approach is recommended for urgency without organ dysfunction. Continuous monitoring in a critical care setting is essential. Immediate BP management. The general target is to reduce mean arterial pressure, or MAP, by 20 to 25% within the first 1 to 2 hours. The goal is then to bring blood pressure down to 160 over 100 millimeters of mercury within the next 2 to 6 hours, with normalization over 24 to 48 hours if there's no critical organ damage. Pharmacologic agents. Now, let's talk about some of the most commonly used IV medications. Labetalol, a combined beta and alpha blocker. Start with a 10 to 20 milligram bolus, repeating every 10 minutes, or using continuous infusion. Esmolol, an ultra-short-acting beta blocker, ideal for tachycardia-related emergencies. Begin with a bolus of 250 to 500 micrograms per kilogram, followed by infusion. Nicardipine, a calcium channel blocker, perfect for stroke or general emergencies. Start at 5 milligrams per hour and titrate up. Nitroglycerin, primarily for preload reduction in cases like acute coronary syndromes or pulmonary edema. Special considerations for conditions. Treatment for hypertensive emergencies should always be tailored to the specific underlying condition. Aortic dissection. The priority is rapid blood pressure control. The goal is to lower systolic BP to less than 140 millimeters of mercury within an hour. First-line agents include esmolol or nicardipine. Ischemic stroke. For patients eligible for thrombolysis, maintain systolic BP below 185 millimeters of mercury to ensure safety during treatment. Hemorrhagic stroke. Blood pressure reduction must be handled cautiously. Aim to lower systolic BP to less than 140 millimeters of mercury using agents like nicardipine. Eclampsia. In cases of hypertensive emergencies during pregnancy, first-line agents include labetalol, hydralazine, and nifedipine. Additionally, magnesium sulfate is critical for preventing seizures, starting with a loading dose of 4 to 6 grams intravenously, followed by a maintenance infusion. Now let's focus on hypertensive cardiogenic pulmonary edema, a condition where elevated blood pressure is left ventricular dysfunction, leading to fluid accumulation in the lungs. The primary treatment goals are to 1. Reduce preload, 2. Decrease afterload. And 3. Improve oxygenation. Nitroglycerin is the drug of choice in this scenario. Begin with an infusion at 20 micrograms per minute. Titrate up rapidly in increments of 15 to 20 micrograms every 3 to 5 minutes, aiming for an average dose of 100 micrograms per minute. The maximum dose can go as high as 400 micrograms per minute if tolerated. If an infusion pump is unavailable, nitroglycerin can be delivered as intravenous boluses. A 3 milligram bolus every 5 minutes is effective for reducing blood pressure and alleviating pulmonary congestion. This approach corresponds to a high infusion rate of about 600 micrograms per minute. For sublingual nitroglycerin, a standard dose of 0.4 milligrams every 5 minutes for up to 3 doses is equivalent to an infusion of around 80 micrograms per minute. Loop diuretics, such as furosemide, may also be used for volume control. However, they should be administered cautiously to avoid abrupt drops in preload, particularly if the patient is already hypotensive. Contraindicated agents. Certain medications should be avoided in hypertensive emergencies. Clonidine is too slow-acting for acute management. Immediate-release nifedipine can cause unpredictable and excessive drops in blood pressure. ACE inhibitors or ARGs are contraindicated during pregnancy due to their teratogenic risks. Be cautious with nitroprusside because of the risk of cyanide toxicity, particularly in patients with renal impairment. Monitoring and follow-up. Patients experiencing a hypertensive emergency should be admitted to critical care for continuous monitoring of blood pressure, heart rate, and end-organ perfusion, such as mental status and urine output. Once the blood pressure is stabilized, transition the patient to oral antihypertensive medications. Ensure close outpatient follow-up to maintain long-term control and compliance. Key takeaways. Let's summarize the key points. 1. Always prioritize organ function when setting blood pressure goals. 2. Use titratable IV medications for precise control. 3. Monitor for side effects, including hypotension or worsening organ perfusion. 4. Tailor treatment to the patient's underlying condition and specific clinical needs. That wraps up our comprehensive guide on hypertensive emergencies. If you found this video helpful, please give it a thumbs up, share it with your colleagues, and subscribe for more medical insights. Thank you for watching, and see you in the next video.